doctors, the NorthShore leadership, and everyone who'd helped, including Ami Algren, with setting up this seminar series, and also our first responders and everyone on the front lines. NorthShore Outcomes Research started in early 2009 with a mission to enable community access to care, enrich the practice of medicine, and based on outcomes research in our health system. And based on an extensive outreach, including a listening tour and surveys and speaking to many stakeholders, we found that there was value in having a silo-free team science approach to bringing investigators together. So the goal of this series is really to help our investigators to flourish by finding each other and to disseminate this research and our activities of our investigators to our health policymakers and the healthcare system and the community. And we really want to promote this team science through our expert panel and incubator hub at the end of this talk. And we hope that this will help inform decision-making around very challenging questions during the COVID pandemic and beyond. Next slide. So Robbie is going to provide some instructions on navigating the Zoom seminar.
Thank you, Dr. David, and hello, everyone. So in today's webinar, all attendees will be muted with the exception of our panelists and speakers. However, there will be some opportunity for interaction. If you have any questions or comments at any point during the presentation or the Incubator Hub discussion, please submit your communication by using the chat function as noted by the blue arrow on the bottom of the screen. If you are on a computer, you can access this icon by hovering over your mouse over the bottom of your Zoom screen. I also want to give special attention to the audience of your message before you submit it. As you can see on the image to the right, you can choose who you want to send your message to. It can be to all of our panelists and speakers or to everyone who is attending the webinar today. If you are experiencing any technical difficulties, please let me know by messaging all panelists and I will assist you the best I can. I'm going to go ahead and hand it back to Dr. David, who will kind of go over our agenda for today. Next slide, please.
Thank you, Rabia. So this is an outline of the seminar today. We're going to start off with a lecture from Drs. Oshman and Kaplan. That will run until 3:40, and at that time, we'll have time for questions and answers taken from the chat. So please collect your questions and submit those towards the end of the talk or at any time along the way. Following that, we will introduce our expert panel, and our panel is represented by Tyler Bauer, representing NorthShore Primary Care, the medical group, Dr. Kaplan, and Dr. Kathy Kennard, who is the director of the Skokie Public Health System. I'll get into more details and proper introductions after the lecture. And then we'll have a time to wrap things up, and we hope that during that time between 3:50 and 4:30 that we'll have lots of questions, comments from the chat, and we can develop some dialogue around the results of the talk. Next slide. So I'd like to introduce our two speakers. Dr. Lauren Oshman is the Vice Chair of Quality in the Department of Family Medicine at NorthShore University Health System. She's also a Clinical Assistant Professor at Pritzker School of Medicine at the University of Chicago. Dr. Amanda Kaplan is the lead physician for immediate care at NorthShore, and she's also a Senior Clinician Educator at the Pritzker School of Medicine at the University of Chicago. Next slide. So take it away, Drs. Oshman and Kaplan. And thank you very much for joining us today.
Say thank you so much to Dr. David and Rabia and the whole team for inviting us to be part of this today. I'm going to ask them to just wave at me or text me or something if the sound quality is bad, and then if I have to switch to a telephone, it's just because we're all trying to make the most of our internet connection here. We're very, very excited to be able to share the results from a small study that we performed from early March until now, based on some experiences we all had in immediate care. I'm going to start out by introducing our study to you, and then I'll introduce Amanda Kaplan, and she'll help me with some of the background information that led us to this study. So Robbie, if you don't mind, move to the next slide. So this is our timeline of events that lead us up to testing for COVID in immediate care and led to our clinical question about how to really make the most out of our evaluation process in immediate care. As you know, the first cases of pneumonia were identified in Wuhan, China in late December, which seems like a world away from right now. In January, the first cases in cluster were identified in Washington State, clustered around a nursing home. And in Illinois, the first case was identified in late January. By that time, leaders in our organization were nimbly moving forward to set up sites so we could do respiratory care clinics and testing. And 4 immediate care sites were rapidly converted into testing sites around the beginning of March, probably around March 11th. And this whole time, Dr. Karen Collin and really our entire laboratory staff were working on setting up a rapid in-house COVID test at NorthShore. We had our first patient hospitalized on the 11th, and then on the 12th or 13th, we began our first testing at immediate care. On the 21st of March, Governor Pritzker issued the stay-at-home order, and at that point, we all had a great deal of fun at home with our children. And then around March 22nd is when we set up a sample timeframe for our study. So we were able to identify our experience in immediate care early on and ask some key clinical questions about its effectiveness. And what we're going to present to you today is an analysis of this 1-week timeframe. Next slide. So I'm going to ask Dr. Kaplan to take us through a sample case and through how we started testing in immediate care.
Hi, everyone. So we're going to start with a kind of a pretty classic case presentation that we were seeing for COVID, especially in the outpatient centers where we had more minimally symptomatic patients that were coming in. So Noelle is a 24-year-old female with 5 days of fever up to 99, quote unquote fever, productive cough, shortness of breath, chest pain, ear pain and congestion, headache, rhinorrhea, sore throat, some muscle aches, diarrhea, and fatigue. Past medical history, she was a former smoker, but no asthma. And the only significant social history is that she had gone to a St. Patrick's Day party in downtown. Her vital signs in the immediate care were fairly normal. She was afebrile with a normal oxygen level. She did have a little bit of nasal turbinate redness and a little bit of erythema at the back of her throat, but otherwise her lungs were clear bilaterally. So, should this patient be tested for COVID-19? So, where do we start with testing? So, NorthShore's in-house PCR testing for RSV and flu negative patients that met IDPH criteria were tested. We were ruling out flu at that point before running COVID testing. So at the time, the IDPH criteria was fever and or signs or symptoms of a lower respiratory illness, i.e. cough or shortness of breath. And they had to meet one of some very specific criteria, that they had close contact with a suspect or lab confirmed COVID-19 patients within 14 days of symptom onset. They had history of travel from an affected geographic area, which at that point were 5 different countries: China, South Korea, Iran, Italy, and there was one more, and I'm not blanking on what it was at this point. They had to be, or they could have been a resident at a staff or congregate living or healthcare facility. If they had a higher risk condition, i.e. age over 65, or some kind of chronic medical condition like heart or lung disease, or an immunocompromising condition, or the rest was left up to clinical judgment if the clinician that was evaluating the patient deemed them a high priority for testing after consultation with public health. So NorthShore's early approach to ambulatory testing, which has drastically changed over that time since we have had an increased capacity for testing, but our in-house testing allowed NorthShore to be a system leader in community testing in the state of Illinois, while other organizations were constrained to testing only by IDPH or CDC criteria and wait times as long as 1 to 2 weeks for results. NorthShore had the opportunity to expand with in-house testing to several hundred patients a day, tests a day over just a very short period of time. At the same time, Tyler Bauer, who's our VP of Primary Care, and NorthShore's administrative teams worked together with the clinical leadership in immediate care, including Dr. Brigham Temple, Dr. Cindy Carpo, and myself, to launch both online and telephonic patient scheduling platforms to help drive concerned patients and families into visit slots at our 4 designated COVID clinics. The weather in early March was not ideal for drive-through testing, so that took a little bit longer. to expand into March and early April when we were able to get that set up. And even though we consistently had enough PPE for our patient volume in immediate care, we would not have been able to screen all concerned patients at that time. But this question still remained of who should we test? In March, there were basically no clinical studies to help direct our decision-making. CDC and IDPH were using hospital data reports from China and anecdotal reports from Italy and other hotspots. But we were lucky to have clinicians on the front lines who very quickly were able to start see patterns in these patients and develop a system to triage patients who were most likely to be COVID-19 positive. Next slide. So this was our early algorithms, which is very, very tiny compared to our current algorithms, which take up entire spreadsheets. But because we did not have enough tests at the time to test every patient with mild possible COVID symptoms, Dr. Temple, Tyler Bauer, and the leadership team, including Lakshmi Halasamani, came up with a risk assessment protocol, adapting and expanding the IDPH criteria to guide some patients to receive a COVID test as part of the medical assistant or actually nurse practitioner rooming protocol, followed by a clinician evaluation by a doctor or nurse practitioner. Other patients who were deemed low risk were evaluated by the clinician first, who then could make the clinical decision whether or not to order a COVID test based on what they saw. Next slide. So this is what the risk assessment protocol that we developed came up with. This was actually Dr. Cindy Carpo's idea. These questions were originally being asked by the PSAs at the front desk, and that created a lot of different concerns with, one, the patient spending more time with our PSAs who did not have PPE, in addition to not always being the most accurate. So we were able to utilize nurse practitioners that were still in training at the immediate care to have a clinician do these risk assessments to also be able to evaluate their medical history if whether or not that put them at high risk. So we developed some templates and protocols where the nurse practitioners would call the patients out in their cars and ask them through these series of questions. So this is basically what it looked like during the time study period. They would ask, were they having any symptoms at all, such as a cough or fever, to judge whether they were symptomatic or not. We then looked at their medical history, and for Noelle, she did not qualify as having any high-risk medical issues. She also had not traveled to anywhere of the high-risk areas in the past 21 days. She had also not been in contact with anyone who had COVID or was currently under investigation for COVID. She had been to a large gathering, but at that point, large gatherings were defined as conferences, sporting events, or concerts where someone was known to have COVID. So her party at St. Patrick's Day would not have qualified. So according to the CDC guidelines, she was considered low risk. We would let the patients know they may not qualify for COVID testing, but they would be evaluated by a practitioner first. So the doctor who saw this patient did feel that she was high risk based on potentially the St. Patrick's Day party that she attended. So they did order a COVID test and she did come back positive. She recovered from her illness without any major concerns and did not require hospitalization.
Thanks so much, Dr. Kaplan. So this really led us to our research question. Early in the response to COVID, we had Dr. Kaplan and Dr. David working in immediate care consistently, and they very quickly had some sort of clinical idea or gestalt based on patients' symptoms or risk factors or what they were seeing about which symptoms might be related to COVID. And in fact, we added anosmia to our screening protocol a couple of days after the very, very first case report came out of England saying that was a risk factor. But I remember talking to Dr. Kaplan about that the week before, saying, wow, it seems like they're missing something. It's anosmia. So, you know, very quickly our clinicians were coming up with their own internal way to think about this. And that's really what you have right at the beginning of a new disease is just clinical expertise. So I was lucky to be able to staff immediate care with them in those weeks. That's me and my PPE, and had that steep learning curve of trying to figure out through history and physical which patients might be positive and negative. So Sean David, Dr. David, in discussion with me, I think at immediate care at the Research Institute said, I wonder what really is the efficacy of this risk stratification protocol. Are our low-risk patients actually less likely to be COVID positive? We put a lot of energy into creating this tool and having the nurse practitioners administer it. Do they have better outcomes, and is it effective? Next slide, please. So in order to test this question, to answer this question, we came up with a research study design and a specific aim, which was to characterize the performance of our risk assessment protocol, risk stratifying patients into a low risk and high risk group for COVID testing, and also to identify additional risk factors associated with test positivity. Were there things we were missing that when we looked back at the clinical data would have predicted their test positivity? So we came up with a design that was a quasi-experimental observational cohort. It was just a cohort of patients without a control from immediate care in this sample time frame of the 22nd through the 28th of March. Even though we had patients of all ages at immediate care, for the purposes of this study, we looked at patients age 16 and up. The number of younger patients was so small that we would not have been able to assess that difference in vital signs really. Their symptoms of COVID, these were not asymptomatic patients, and anyone who completed a visit at a super site, knowing that there were patients who scheduled visits but didn't show up. The exclusion criteria, as I stated, asymptomatic patients and people under age 16. This study was IRB exempt. We don't really anticipate these particular results to be applicable outside of the organization, and we met NorthShore's quality checklist for quality improvement study design. Looking at the variables we wanted to look at, we tried to think of anything that we thought would be related to COVID test positivity. And again, in early March, there really weren't a lot of studies to base this on. So we looked at age, gender, vital signs. We collected data about BMI, the presence of chronic disease risk factors, and smoking history. What we then noticed in data analysis was that in immediate care, while our patients had one-third of them had COVID, we were not stopping to check a height and weight, so we didn't have an accurate BMI on most of the patients, and we were not able to analyze that data. And as well, smoking history, we weren't going back and taking an extensive smoking history, and not all of those patients had an existing chart at NorthShore. We were able to extract the risk assessment questions, those IDPH questions, using natural language processing from the data warehouse with their low or high risk designation. And then we were able to capture outcomes from data fields from the EDW, looking at whether they were tested for SARS-CoV-2, whether the test was positive, did they have an ER visit, hospitalization, ICU admission, intubation, or death related to COVID within 2 weeks of the end of our 1 week study period. So that was through April 10th. And then we did some manual chart review to confirm the ER and hospital outcome data. So I have to thank the people who did this work: Urmila Ramachandran and Nirav Shah, Elena Genova-Piva and Rabia Ali, and Rabia Khalid, internal medicine resident, who helped us with that manual chart review. I want to put this all into context, though, about what was happening at the time at immediate care and how our testing has grown at NorthShore. And I want to thank Chad Konchak and his team. If you like data and you like graphs, there's a host of wonderful information about COVID at NorthShore. So you can see our study window between the 22nd and 28th, that this was when we were just starting to do testing. This was our 1,000th through 1,800th test. Next slide. But you can see, looking at the number of daily tests, that this was one of our peak testing times. So one of the peak testing days, 309 tests, was during this study period. We had really ramped up to almost peak patient volume at that time. Test positivity, one of the questions that we had picking a study window was, is this relevant to a particular time period and prevalence of disease? So these results are going to be most prevalent when your test results are in the positivity range of 19 to 25%. Subsequent to that week, you can remember the stay-at-home order was placed, I think, on the 21st of March. Test positivity rates went up a little bit in our neighborhood, around 30%, and then came back down. Some of that is due to probably dilution from asymptomatic and pre-op patients, but also largely because of improvement in stopping the spread of COVID. And then looking at how many patients on any given day were positive. It's helpful if you're trying to do a study to look for positive results to pick a peak period, and that is what we did. We saw our peak number of daily positive test results during the study period. Looking at hospitalizations and stepping backward to answer the question, can we talk about outcomes such as hospital stay as it relates to our immediate care population? At this point, the hospitalization numbers were still quite low. So even looking out through April 10th, we only had, I think, 35 cumulative hospitalizations. And so, you know, the question for me is whether we would be able to demonstrate any outcomes from this generally low risk immediate care population. So what did we find? What were our results? Looking at this 1 week time frame, there were a total of 1,542 patients, 16 years and older, who completed an immediate care visit, got the risk assessment protocol, and were evaluated. Looking at those numbers, about 68% fell into the high risk category. They answered one of those questions positive and were placed in high risk, and 32% were in the low risk category. What was statistically significant between those groups? The answer is not much. Age was statistically significant, but remember, that's how we built the protocol. If you were 65 and older, you automatically fell into the high risk category. So that was meant to happen. Between females and males, there really was no difference. Next slide. Looking at some vital signs between the low risk and high risk group, the pulse ox was about the same between groups with a non-statistically significant p-value. Temperature was the same. Pulse was the same. Respiratory rate was slightly different, statistically significant, as was diastolic blood pressure. Next slide. And then looking at chronic conditions, this was again how the algorithm was built. The nurse practitioners asked the patient, do you have a chronic condition such as heart disease, diabetes, chronic lung disease, asthma, chronic kidney disease, or something that would make you immunosuppressed? And so that not all of the patients in the high risk category had that, meant that the patient just didn't say yes to that question. But as expected, most of those were more likely in the high risk compared to the low risk population. This, I think, is the most interesting piece of our clinical study. This answers the question, how useful, how efficacious was our risk stratification criteria? So if you look at our entire population of patients in the low risk group compared to the high risk group, you can see that almost all of the high risk patients received a COVID test because we intended them to. The 3.5% that did not receive a COVID test, after the clinician talked to them and got some more history, they really thought maybe the patient had strep throat or an ear infection or something else, and they discontinued the test. But of the patients who were low risk, after the clinician did an interview, a history, a physical, and had to make a decision, they decided to test half of the patients. So the work that we put into, and again, we really had to, we didn't have enough tests to go around for all of these patients nor PPE. For me, if you still have to test half of your patients, that risk assessment protocol may not help you so much. It may, again, depending on the constraints of testing at the time. What happened with the test results? The other thing we were really interested in was, is there a difference? Are those high-risk patients more likely to be COVID positive than the low-risk patients? And the answer again was no. 22% of the patients who received a test were positive in the high-risk group. And of that, half of the low-risk group that we tested, 19.8% were positive. So I guess you could say that the low-risk patients that the clinician decided not to test might have been negative if they'd been tested, but we weren't able to look at that. Some other data that we did obtain, but was not significant on analysis, did patients come back within 2 weeks? Did they have to come back for a second test? Those numbers were about the same between the low risk and high risk groups, and the high risk group was slightly more likely to have a positive COVID test in that 2 week period, but not statistically significant. Looking at ER admissions, there's a very small difference between the low and high risk groups, again, not significant, as well as hospitalizations similarly, right at a p-value of 0.05. If we'd had slightly more patients, maybe it would have been statistically significant, but 20 or 1.9% were hospitalized in the high risk group, and only 3 or 0.6% in the low risk group. Next slide. The things we really care most about: utilization of ICU beds and ventilators, intubation, and death, the characteristics that we'd really like to change. Just taking a step back, we had this huge data sample and a small number of these patients that came through immediate care, through almost a primary care, immediate care setting, had negative outcomes. Only 5 were hospitalized in the high-risk group, only 4 intubated in the high-risk group, and only 2 deceased in the high-risk group. And that was not significant between the 2 groups, and we weren't surprised to find out we didn't have enough patient volume to compare those 2. Next slide. So the last piece of data analysis that we did was a logistic regression, holding all of the other variables of interest. What was most associated with the odds of testing positive? And so again, holding for age, gender, those vital signs that were abnormal, the health comorbidities such as heart disease, and their answers to the risk stratification questions, close contact with someone who was COVID positive, recent travel. This is what came up as maybe things that were associated with a positive COVID test. Age, not only over 65, but age over 45. So starting to look at that increased age compared to age 44 and under as a cutoff. If we were going to do this again, maybe I'd pick that cutoff as where it starts to be associated with odds of testing positive. But that again is in a cohort in early March. Now we're finding out that most patients who are COVID positive at this point in time are younger. Male versus female was not significant compared to the referent range, I think. Pulse ox, p-value of 0.048 in the adjusted odds ratio, just slightly significant there. You can see the 95% confidence interval just goes to 1. I lied actually about male and female. Males more likely than females, slightly more likely. But then temperature and pulse were not any different between the 2 categories. Next slide. Looking at the other data that we were able to analyze, respiratory rate was the same. Systolic blood pressure was slightly different, that SBP under 120. Heart disease, no different. Diabetes, no different. Lung disease, no different when you adjust. And asthma, no different when you adjust. Next slide. Looking at the answers to the questions in the IDPH algorithm that we were given, no difference at that point in time with high-risk conditions when adjusted. No difference with recent travel. But we do see that if you had a close contact who was positive or being tested for COVID, that made you more likely to test positive, as well as attending a large event. And then when we added this question, loss of taste or smell, that ends up actually having the largest effect size with odds of 2.83 compared to the other ones that are in the 1 range. And so that was actually most associated in our study sample. Next slide. So this essentially are the results of our study. And so how did we interpret these and put these into context? Well, it's a single site. We have to take into account our test positivity, prevalence, and risk factors at the time of the study. No one was going anywhere at that point. Our data set was limited. If we had access to other data pieces, we would have been able to answer some more questions about BMI and smoking particularly. We would hope that all community patients would have been coming in for tests. We were careful to advertise that regardless of insurance, patients were eligible to come be seen in immediate care. We had the Health 9 line available for them to be able to call for an appointment, even if they didn't have NorthShore Connect. But patients with low socioeconomic status may have been less likely to seek care. And we do have access to our own hospital outcome data, but missing data outside our system. So if someone went to a different emergency room, we may be underestimating the findings related to hospitalization. Next slide. From these results, we would make the conclusion that in this cohort of symptomatic patients in a primary care ambulatory setting, our risk assessment that was based on the CDC and IDPH testing criteria was not effective at predicting test positivity. And in fact, half of our low-risk patients were ultimately tested and their risk of a positive test was about the same as a high-risk patient. Next slide. Future risk assessment protocols may want to incorporate the risk factors that we found to be associated with positive COVID test, as well as keeping some of those useful questions that I think apply to recent findings of young people being more likely to be COVID positive attendance at a large gathering, and certainly decreased ability of taste or smell. And with these, decreased taste or smell had the greatest effect sign. Next slide. So this leads us to the questions that I have at the end of our study. Is there any risk assessment protocol that is sensitive enough to decide who to test? In other words, when you look at hospitalized patients or an ER setting, you are more easily able to find those patients with negative outcomes. But in an immediate care or primary care setting, is there anything we can do to predict who's more likely to be COVID positive? What kind of policy, funding, or public health interventions would be necessary then if we're going to say that there is no adequate risk assessment protocol? You have to test everybody to make sure you can test everyone who needs testing. And what have other studies said since March about evidence for prioritizing patients? Next slide. So there are a couple of studies I want to share with you. One is a systematic review and critical appraisal published in April 2020. And this study looked at preprints and publications looking at patients with suspected infection for diagnosis of COVID, prognosis, and detecting people in the general population at increased risk of becoming affected. So out of all of the titles they screened, 51 studies describing 66 prediction models were included, and that identified 3 models for predicting hospital admission from pneumonia and other events, 47 for detecting COVID-19, and 16 prognostic models for predicting mortality risk and progression. Next slide. So of all of these studies, the frequently reported predictors are, as you might expect if you've been following the literature, in addition to clinical signs and symptoms, features derived from CT scans. But in conclusion, I'll just read out to you what's bolded. This review indicates that the models are poorly reported, at high risk of bias, and we do not recommend any of them in clinical practice. Next slide. And so just hot off the presses from July 7th, I'm glad that we scheduled this talk for today and not 2 weeks ago. A Cochrane review has now been published on looking at signs and symptoms to determine if a patient presenting in primary care or a hospital outpatient setting has COVID-19. And this again identified 16 studies, but there were no studies from a primary care setting, although they did find studies from outpatient clinics and an emergency department. I would argue that our immediate care site is a primary care setting, so I'll have to look further to see how they would have analyzed it in this Cochrane review. So I'll just again read to you the bold on the prior slide. Most of the protocols had low sensitivity and high specificity. 6 symptoms that had a sensitivity of at least 50% in at least one study looked at cough, sore throat, fever, myalgias and arthralgias, fatigue, and headache. And the red flags might be fever, myalgias, fatigue, and headache. Next slide. And so the conclusions are none of these studies are able to rule in or rule out disease. We need more prospective studies in an unselected population presenting to primary care or hospital outpatient settings, examining combinations of signs or symptoms to evaluate for COVID-19. And these are urgently needed, especially studies in older adults. So I do think that our study fills one of these gaps, looking at that unselected primary care setting. And unfortunately, or fortunately, we find that our algorithm was not able to identify or pinpoint accurately which patients should be tested. Next slide. So that is my dog. I will say thank you and turn it back over.
Next slide, please. Thank you, Dr. Oshman and Dr. Kaplan. It was honestly a really great experience, part of the project, and seeing everything come together. But at this time, we can take a few questions from the audience. As stated earlier, please input any of your questions in the chat box. And whatever we are not able to address, feel free to contact Dr. Oshman at her email listed on the screen. If there aren't any, I'm going to go ahead. Oh, I see a question here. The risk factors for COVID in the last study you cited should be predictive for almost any viral illness. Specifically for COVID, would be poorer outside flu season.
Dr. Kaplan, any comments about the overlap on COVID and flu symptoms in the immediate care setting?
So it's something we have struggled with going into thinking a lot about flu season coming up. I've been telling colloquially people that flu has a look. You know, when someone comes in with the flu, their eyes are hooded, they have their hoodie pulled up over their head, they're laid on the table. COVID just doesn't look like that. COVID looks like a sinus infection. It looks like just a loss of smell. It looks like just someone who's tired and achy. These patients don't look sick, especially the majority of patients we see in the immediate care who are mildly symptomatic. It just doesn't have a look. And it's something I've been trying to impress upon all of the primary care doctors, that just assume everybody has COVID. It just doesn't have a look that's helpful.
I see another question here. Are there any additional symptoms that you or other immediate care providers heard from patients?
I think the ones that always stick out to me are the chest symptoms. People come in describing this chest discomfort very differently than how I'm used to them describing chest discomfort from bronchitis or a normal cold with a cough. They come in really concerned about tightness, pressure, and again, these are mostly young people who normally wouldn't describe their colds that way. They might tell me about they have a terrible cough, or the cough's keeping them awake at night, but these patients aren't complaining so much of the cough, they're complaining of the chest discomfort. So that's, to me, always a red flag when I hear it, along with the loss of taste or smell is always a red flag every time.
All right, I see another question here. Do we have any data of patients screened for non-respiratory symptoms with positivity categorized as low risk and high risk, or is this a limitation of the study?
So it's a great question. I think moving forward, now that we have some idea, at least from this early cohort, what the numbers of positive and negative patients are, we could come up with a population needed to statistically look at some of the individual symptoms. At this point, that would require a complete chart review because we didn't have any discrete way to characterize symptoms. If we could have gone back, Dr. Kaplan, we should have come up with a laundry list of 3 pages of symptoms and had patients check each one so that we could have answered these questions. And so, you know, what I think our job is in looking at our processes in immediate care is to help make NorthShore's processes run the best we can for patients. Other studies with huge data sets have looked at some of those other questions about what other non-respiratory symptoms have been related. And that's a little bit of what you saw in the Cochrane review and the other BMJ review.
Okay. I see another comment here from Brittany Smart. My understanding is that the goal of the screening tools are to save on costs and to best guide resources or tests. Considering these are not as effective, are there any other strategies for determining how resources should be allocated?
So Dr. Kaplan and Dr. David, I'm curious as to your feelings about that, being at least in immediate care. We can't control who walks in the door. Certainly looking at people who live in a nursing home, that's a high-risk group, but looking at immediate care itself.
I think it's a really great question because we can't do universal screening yet, but with limited tests, is it useful to risk stratify when some of the variables used to risk stratify don't really predict risk of positive tests? Many are actually risk of a bad outcome if one gets infected. So having type 2 diabetes, older 65, than over 65, chronic lung disease. And yet those are the patients we want to know if they're infected. So if we're going to have a streamlined way of testing the people where there's the most value in terms of reducing bad outcomes, I think we need something that has some pretest probability that's going to be useful. And then if someone tests positive, we may have a stepped care approach to their management for complex patients. So we need something, but I think that we ought to have a sensitive set of screening questions that are going to have higher yield if we have to ration the testing.
I would like to add that something we haven't talked about here is that the e-visits have a wonderfully, might say complicated, others might say very detailed algorithm to really try to press into all of these risk factors and high-risk symptoms. And so I think that e-visits have actually been a wonderful way to allocate those resources into who is high risk, who is low risk, who should just quarantine at home. I know it's tremendously reduced the volume burden that the immediate care has had to go through. So that's been, I would love to see a study done on the e-visits because those have just been really remarkable for how much they've been able to streamline care.
Thank you, Dr. Kaplan and Dr. David. There's another question here. Are there any studies looking into long-term side effects?
So I'll just speak to you from what I know is that primary care physicians being the group that are taking care of patients once Dr. Levinger and our colleagues in the hospital have discharged them and asking these same questions. Patients still can't smell after a month. They're exhausted all the time. They got chest pain. They can't go back to work. They're depressed. And I know that at Mount Sinai, I think the Mount Sinai in New York, there is a post-COVID clinic looking at the follow-up and care of these patients. And that has just started. And so I suspect in another few months, we'll have some ideas, but anecdotally, your colleague who can't taste or smell, I think is not alone. A lot of people are wondering what to do about some of these long-term symptoms. Dr. David or Kaplan, any other suggestions?
I think that I'm aware of evidence of endovascular damage from COVID and the long-term effects in terms of cardiopulmonary disease are probably substantial, and yet it's really beyond my area of expertise. But yeah, we have yet to find out the long-term complications of chronic COVID pneumonitis for our patients.
Yes, and Dr. Levinger, thanks for typing in some of the other issues that have been a persistent issue, hypoxia and exertional dyspnea and limitations for patients. The questions we have about using therapeutics to help prevent hospitalization and prevent intubation for COVID, we don't know the answer about these patients who are having continued persistent issues later on. And I don't know of any studies that are being designed right now to look at, does it make a difference to give interferon beta or prednisone based on does someone have symptoms months later?
I think I'll just help give voice to Brigham, Dr. Temple here. He was responding to Tom's question about should we be focusing less on risk and more on controlling spread with using our testing to that capability. You know, the original testing modality that or the original algorithm we use here was looking at who was most likely to test positive and also who, if they test positive, was at highest risk of a poor outcome. You know, hindsight being 2020, looking back, it would probably have been nice to focus much more on who's going to spread the disease and focusing our testing on those patients more than just who is higher risk.
Yeah, that brings another question here. Currently, is there any clinical benefit to identifying COVID patients early during the course of disease, aside from contact tracing or quarantine? If not, then why test based on clinical risk versus based on risk of spreading to others?
I think this is a great question. And really, if you ask me to wave a magic wand, I would just say test as many people as you can, as rapidly as you can. So when you are not in NorthShore's area and you go to a CVS Minute Clinic for a test, it can take 5 or 10 days at this point to get your test result back. And it really does nothing for this idea that Dr. Temple is bringing up, that why do we need a test result to change our behavior, to keep us from going out in public when we have symptoms of an infectious disease? I think at this point I've just embraced that that's how Americans feel. And I want to test as many of them as possible. And so, you know, for me, the answer to that question is just test as many patients with these rapid resulting tests as possible. And I think NorthShore's community has been so benefited by having rapid test results come back.
Absolutely. I see here another question. The data on returning patients can be a tool to see and correlate any symptom change next time. Is that being looked at?
So we are currently undergoing a study led by Janu Kandahar in the immediate care that is looking at continuing to test mildly symptomatic patients, both looking at their symptoms. We're following them for 8 to 12 weeks after their positive diagnosis, continuing to look at symptoms, how that correlates with nasal PCR, some viral loads that are being done at University of Chicago, and their antibody testing. So that is something that's currently being looked at here at NorthShore in the immediate care.
Okay. Yeah, I see someone, Aaron, has put in the chat here. The CVS SARS-CoV-2 testing now takes 12 to 18 days. They will test anyone, but the result is testing backed up for everyone. Yes.
Obviously,
the result for receiving tests is being backed up for everyone.
Yeah. So obviously talking about the utility of the timing of the testing, we've all had our fair share of patients who left our facility despite our warnings and went out to dinner until they got their positive test result the next day. So the quicker we can get those results, having a rapid test available in our clinics would make a huge difference for getting everyone on board. But I know we're scientifically, logistically not there yet.
And I think Dr. Temple's point as well for why test patients at high risk for bad outcomes, using some of the characteristics from the Cochrane review and the other BMJ study to say, these are the patients that we're going to provide a home O2 monitor or have a home nurse check in with them every few days, bring them into the emergency room, because in the emergency setting, what we've seen is that patients go from not very well to incredibly sick and needing to be intubated in just a few hours time. And so that absolutely, thank you for bringing that point up.
I just also wanted to interject that the fact that immediate care stood up these super sites virtually overnight and tested thousands and thousands of patients applying CDC guidelines is really extraordinary. And one of the observations as a family doctor is that the eyeball test might be as useful to determine risk as the CDC criteria. And yet that we can't do that in a scalable, systematic way. But when there was reclassification, things looked very similar between the groups. And so it may be something about if patients feel the need to get tested, that's picking up on something right there, that they're sick enough, they're worried, and they just don't feel right. And so capturing that patient perspective in the testing algorithm would be really interesting if people can do the fancy AI natural language processing about patient complaints to see how do you build that into the model too. As Logistic said, always listen to the patient. They'll tell you the diagnosis.
I'll just respond to this last addition from Dr. Mohammed Jamil. We had a small number of patients that came back for a repeat test in the next 2 weeks, so that didn't end up being statistically significant. So I don't think that this study can speak to people who had a false negative test early in disease, just to note that none of our testing is perfect, and our NorthShore PCR test performs very, very accurately. Okay,
we have, actually it's time to segue into our expert panel. And these are fantastic questions, and congratulations, Dr. Osman and Kaplan, on a really exciting talk. It was a jaw dropper to see no significant difference between the high and low risk groups for test positivity. So on that note, I'd like to introduce our panel. So we have 3 expert panelists who will provide some additional insight into the implications of this research. First, we have Dr. Catherine Kennard, who is the Director of Health for the Village of Skokie. We have Dr. Amanda Kaplan, who is one of the co-presenters today, lead physician in immediate care. And we have Mr. Tyler Bauer, who is the Vice President of the Medical Group at NorthShore. Next slide. Very good. So I'd like to start off, and these are our 4 discussion points that we'd like to use with each of the seminars going forward. And the first question is really to Dr. Kennard. What do you see are the implications of this research for health equity? And yes, so Dr. Kennard.
Thank you. Thank you for inviting me to participate in today's discussion. And this addresses a crucial topic as we move forward through the pandemic. I wanted to mention that I am initially a family physician by training and have switched to preventive medicine and public health after 10 years in practice as a family doctor in the Navy. So I've been the director of the Village of Skokie Health Department for 11 years. And I just wanted to give you a little bit of the community perspective on this and thank you all again for such a great study and being NorthShore in particular for being wonderful partners here for public health in our area. But I've been here 11 years and Skokie has one of only 7 state certified municipal health departments in Illinois. As you know, we're just north of Chicago. There's a population of 65,000, which makes us about the size of a ward of Chicago at 10 square miles. But the village is interesting because our population is very diverse. 42% of our residents were born outside of the United States, and there's more than 100 languages and dialects. The top immigrant populations also by region are South Asians, country of origin are Filipinos, and we have a very large number of Assyrian refugees. So I think this ties in to show the great relationship between public health and clinical medicine, the whole spectrum of working together, that our role in public health is to promote prevention activities and keep people from becoming ill in the first place. So right now, I am spending most of my time working with all segments of our community to implement the Restore Illinois safety guidance to limit the potential for disease transmission in houses of worship, businesses, childcare centers, the park district, the library, all manner of businesses from small bakeries to manufacturing plants employing thousands of workers. Promoting equity, though, is a core concern for the village based on our very diverse population, and that's a core value for public health, and I think for NorthShore as well. So we are grateful for this strong partnership with NorthShore, who early on launched the COVID-19 test and quickly made it available to everyone who met the criteria, regardless of ability to pay. And I echo the importance of the quick turnaround of NorthShore's COVID-19 test for public health control measures. Unlike what you were describing, we are pretty much directing anyone from the village to go to NorthShore so that there's not that delay in getting the results. We promoted the NorthShore message and hotline number by translating that information into 12 languages that was sent out through all of the organizations in the village and beyond to publicize it widely. And I think it's noteworthy that the Skokie COVID-19 website was visited by 100,000 people every month during March, April, and May, which is unheard of for the village, but I think reflects, again, our partnership with NorthShore and that we had very accurate information about what was happening in our area on our website. We also sent out NorthShore's information through our electronic newsletter, which is distributed to 25,000 email addresses. So as of yesterday, 1,057 Skokie residents have tested positive for COVID-19. 122 have been hospitalized and there have been 35 deaths. And I'm sure that the number of deaths would have been greater without the excellent care they received from area hospitals, primarily again from NorthShore. But looking at the confirmed test results for Skokie residents, it is clear that minority groups were able to obtain testing, which reflects well on all of us, but also that they were disproportionately impacted by COVID-19. So my 2 questions pertaining to equity for the study team would be kind of echoing what was just in the July 17th, 2020 MMWR, the characteristics of persons who died with COVID-19 in the US from February to May of this year, that a higher percentage of decedents under age 65 were Hispanic and non-white, and they were more likely to die outside of the hospital. and that we know, looking at Illinois data, the percent test positivity has been consistently much higher for people who are Latino or Hispanic, as has the case rate per 100,000. And also that Blacks in Illinois have been dying at 3 to 5 times the rate of whites from COVID-19. So I'm wondering if you might take a look at the data again, taking into consideration race, especially with regards to outcomes. And then a final second question, which then, I'm hoping we can have some discussion about, would be looking at occupation, if that was captured in the NorthShore medical record, because many of the cases in Skokie have been essential workers. And I'd be curious to know if that's true across NorthShore. And, then unfortunately, what we see is that about half of our cases are household transmission, where the worker became ill and then wasn't able to isolate at home effectively, and so then other members of the family became ill. So anyway, my question along the equity lines is, do you think it'd be possible to consider race and ethnicity as well as occupation as additional criteria for screening, especially with an eye towards preventing worse outcomes?
Thank you very much, Dr. Kennard. And also to add to that question, Dr. Solomonides had a question related to whether the same disparities in test out results and outcomes were observed at NorthShore.
Do we have time to respond?
Please, please.
I just, hearing how you reframed this question of how do we capture patients who are at highest risk, both of bad outcomes, of death outside the hospital, it makes me think about how those initial IDPH and CDC criteria had structural racism built into them. If you had to have had someone in your household test positive or gone to a big conference or went to Italy or had a chronic health condition, that in and of itself shifts testing to a population that ended up not being the group that was most at risk for COVID. So for me, it means like take down the questionnaire entirely and test everyone. But I think another way to look at it is to preference testing based on, we know that race and ethnicity are a crude measure, but potentially to add that in to the additional criteria. When we look at NorthShore's capture of race and ethnicity, a lot of people are labeled as other. Dr. Nirav Shah is on the call. We've had discussions about this and trying to abstract data. We don't get very granular data about race and ethnicity, and so it makes it somewhat difficult. So we may not have the number of patients to power that in this study, but we could look at other data sets as well.
I would like to add to that, Nirav Shah did do a fairly big study looking at the epidemiological data, vital signs, et cetera, of COVID positive patients and hospitalized patients. And one of the biggest risk factors he found, besides patients presenting with hypoxia, was patients presenting that came from a neighborhood where English language was not the primary language. Or coming from lower socioeconomic neighborhoods. So he did establish that even in our NorthShore population, that was a significant risk factor for COVID positivity and poor outcomes. So not part of our study, but using very similar data sets of people, he did establish that. Also jiving a little bit off of what Lauren was stating, that it was a long time before IDPH and CDC took contact with a COVID positive person, then added a healthcare worker, and then very, very near the end, they started to eke out essential worker as considered a high-risk health profession as well. And for a long time, we were really questioning that in the immediate care. And personally, I started testing everyone who worked at a grocery store or had a lot of contact with the population. But that was very, very, very slow to be added in there. As someone who would be considered high risk. And we really didn't understand the rationale behind that because we felt very protected in healthcare. I would not have felt, I used to tell every single person I saw who said, oh my God, how are you doing? Is everything okay? And I was like, I'm fine. The grocery store, no way. I'm not going there.
Well, when we looked at about 40% of our cases, when we look at occupation, have been in healthcare, but many of them were in housekeeping or some other, there were almost no doctors. I think we might have had one who became ill from COVID. And so I know that I'd like to look at that over time and see if those occupational data have shifted. But I know Nirav too, so I'll say hello to him. I saw him thanking you for a plug. He is working closely with the Village of Skokie on the South Asian Healthy Lifestyle Initiative. So we have talked as well about that, you know, and looking at different neighborhoods. But I think it's talking with Dr. Shah, how we could work together with public health, because if NorthShore doesn't have the race data in your database, the local health departments where the person resides may have collected that when they did the case investigation. So it could be an opportunity for collaboration. And I was talking with Nirav about that to see about from community to hospital and back, because so many of our patients actually ended up who were hospitalized ended up at NorthShore. And the vast majority were tested at NorthShore too. So we could, you know, not only just here in Skokie, but with all the other local health departments in the area, potentially do some kind of collaborative project to look at this more carefully.
Thank you. That's a great discussion. And also, I know we're joined by participants from across Chicagoland and other health systems as well. So we welcome your comments on implications for health equity, clinical care, and research. So let's, for now, and we can come back to that. The next question has to do with what are the implications, and this is to Tyler, Mr. Bauer and Dr. Kaplan. What are the implications of this research for healthcare dissemination and implementation science?
I'm gonna let Tyler take this.
All right, thanks, Dr. Kaplan. So I'll start and please fill in the gaps. But for me, in terms of implementation, we really created the e-visit that Dr. Kaplan talked about for a bit in tandem with the immediate care screening tool. These two kind of worked together, and the e-visit tool really provided access, free access and 24/7 access to a very anxious public without inundating the health system or creating additional issues like potential person-to-person spread by further overcrowding our lobbies or offices. So I think that piece was extremely important to the implementation of dealing with this crisis. And then the assessment protocol really allowed for consistent application of symptoms to determine testing, although we found that it didn't really make a difference. But in standing up our COVID super sites where we were testing the majority of our patients, we had to bring in additional physicians and clinicians into that space that were not accustomed to working in immediate care. And so having a tool that these clinicians and physicians were able to use, I think, was helpful in terms of getting them up to speed, getting them up to running, and quickly getting them some information on a novel virus that we were all dealing with. And I think the last thing that that struck me was that this was, although the algorithm was rather complex, especially as we got further down the line, and by the way, we're on version 18 now, it was fairly easy to modify and a tool that was easy to communicate to not only our immediate care clinicians, but also to the public, but also to our primary care physicians that were, and specialty physicians that were fielding a lot of calls from their patients.
So I think the part I would like to, speak to that is that became a really big problem when COVID hit, is how do we communicate with our staff? How do we communicate with our doctors? How do we communicate with administration? And ironically, templates on Epic became the fastest and most efficient way to communicate with anyone. Ironically enough, there were just too many emails, too many phone calls. We did also implement in the immediate care a daily morning phone call just to review everything, go over anything new. Which was very, very helpful, and also it wasn't just a nervous public, it was also a nervous set of providers. And so being able to really have this very significant communication with everyone involved was very reassuring to everyone. But updating these templates to match the e-visits was how I communicated with every single doctor. My exact instructions were show up 5 minutes early and read through the templates, because I was updating them nightly. in congruence with emails from Tyler and emails from Brigham about what were we doing now, what changed last night, what did IBDPH say now. So for dissemination, it was really ironic that that became the communication method of choice. But it was the most effective. It also really standardized the documentation that was coming out of the immediate care. Every single person was using the exact same set of templates with the exact same set of risk factors and high-risk conditions. So that made it much easier for everyone else who was doing research, following these patients clinically, seeing them in the hospital. It really, that standardization of care became very, very important during a crisis like this.
Well, I can speak to that as a immediate care physician as well. Dr. Kaplan and Dr. Temple and others developed template standard language for patients based on positive, negative test results, and a daily huddle, and all these things made it a lot easier to see a large volume of patients and do the testing, as well as all the excellent PPE donning and doffing education that was done. I think for the future, as we bring in more data about predictive models, there's going to be lots of opportunities for implementation science, and that I think is a work in progress. But I think across Chicagoland and our IT institutional translational medicine partners, a lot of people are doing work in this space at our other institutions. So we'd welcome your comments or along the way. We still have some time and a couple more discussion questions. So the next one is, and this is to Dr. Kennard and Dr. Oshman in particular, but any of the panelists, what do you see as the implications of this research for health policy going forward?
Well, I was just reading this question from Emily White Van Gampel, and I just wonder what I was going to say is I would wonder about NorthShore adopting a policy that that any kind of studies, not as a criticism at all of you guys. I mean, I think you did a phenomenal job here. This is so interesting, but would look at studies through an equity lens as you're developing the questions and looking at how you might look at the data. And maybe you already have that as a policy, but, and I don't know, what do you think of Dr. Van Gompel's comment here about, does it need to be read out loud or can everyone see it?
I think everyone can see it, but you can read it out loud.
Oh, okay. Just a comment, I think the reframing of the risk factor from an individual patient's race, ethnicity, which is a social construction, yes, and making the risk factor the racism existent in their communities, e.g. zip code, makes it clear that we have this risk factor well documented in our data. And I don't know what your thoughts are on that. Maybe that would be a policy also to look at any impact of zip codes on outcomes, and perhaps NorthShore is doing that as well.
So I'll just tell you some of the slides I didn't show from our data warehouse that Chad Konchak and his team are updating do show hotspots. And so we are able to see, at least with our own data, where are the areas of higher COVID transmission occurring in terms of tweaking our e-visit protocol or our Health 9-line protocol. You know, I think a good question for NorthShore is it equitable to bring in only symptomatic patients? And if we decide that it is, then how do we make sure that we're adding information that looks through that lens of equity? So looking at each one of those triage questions and asking, how does this triage question affect potentially someone who is undocumented, someone who has low socioeconomic status, someone who might not understand the question, and making sure that we are as equitable as possible with each element of it. I think it's just really interesting when you're rapidly bringing something like this to serve your community. Hats off to the NorthShore team. I think you start to then be able to be reflective a month or two later to say, wait a second, who were we not serving with this protocol? So Tyler, I don't know what other thoughts you have in addition to that.
No, I agree, and I appreciate the shout out. When you're trying to set something up, you're just trying to respond to the current crisis. But I think it's important for us to look at that. One of the things was our eVisit platform was very, very successful. I think we're at upwards of 32,000 or more completed at this point. But that does beg the question. Folks who do not have access to the internet, do not have smartphone, how are they able to get the same information? And we were able to set up the Health 9 number. It did come a little bit, well, it was about the same time, but it wasn't until later that we had the same eVisit questions on the Health 9 number. And I think that really helped things out. And also then having that Health 9 number that patients could call, there was also the opportunity for translation services as well on that line. So I think that's important. But I think looking at the questions that we're asking, that's something that we should probably look at to make sure that we're being as equitable as possible and not leaving out a certain population.
To turn it back over to you, Dr. Cunard, though, NorthShore is a not-for-profit health system. There are things we can't do. And so looking at the funding of departments of public health and patients getting care in their own community in partnership with their local hospital system or primary care physician, I think there are elements where you have greater access to the community than we do, and you know the community better. Each community knows itself better.
That's true. And I was going to say a caveat about the zip codes is that in Skokie and in Rogers Park, there's a large Orthodox Jewish community. And so we know that for different reasons, those individuals had higher testing rates. And so we've been working very closely with rabbis. We've been on Zoom calls with 40 rabbis at a time, working with all the synagogues and so forth to try to make sure that those groups are protected too. So it's not always racism in the zip code, but it is very important to work with the local health departments and local communities to try to understand the community. And that again reflects back to the partnership. Maybe that could be a policy too, that we will do everything possible to collaborate with our local health departments. As some, especially when we're looking at something that's so, health is just a continuum, right? All the way from the community into the hospital and back, as I've said. So I would certainly welcome any opportunities to work with NorthShore on any questions like this.
The only last thing that I would say to that point, and I think Dr. Karen Call was one of our attendees, if she's still on the line, is that we can stand up the capability to test as many people who are likely to test positive or need to test positive, whatever criteria we use, but access to test supplies, test reagent, access to the machines, and then, expanding that outside of NorthShore to the rest of Chicago and Illinois. I think we're all working in this backdrop of our elected leadership and how we are constrained or able to meet the needs of our community. And I just know from being on conference calls with Tyler and others how hard we've worked to make sure that our system keeps running, has everything that we need.
I think Karen responded on the chat.
Right, absolutely.
So Dr. Call raised the question of we are still having significant issues with the supply chain.
So I wish I could tell you that we found a way to limit the number of tests that need to be run. I think the way that we do that is by constraining public activities that are likely to spread COVID so that we're down to a 3 or 4% testing rate, and then expand our testing. At that point, maybe we can bring in more asymptomatic testing or create an expansion of our testing algorithm that's able to bring more people in. But if everybody gets sick, then everybody's sick.
Mm-hmm. I do want to circle back to the question from Dr. White Van Gompel about using race as a risk factor. I think that it's a really good point that race is not a biological construct. It's a social one, in that it captures a lot of heterogeneity and culture and biology. And yet we measure it, we ask it in NIH-funded research because of the disparities exist. So how are we able to notice that there are certain observations of clustering of COVID severity in some communities, unless we have some way to track this. And I think it's a complex question, but and I guess the other thing that I think of is the AIDS epidemic, when people began to look more closely at spread. They asked certain questions, but it really took a lot of careful community engagement work to understand what's happening in communities. Issues around health literacy and other things come up, and resources and access to care and so forth. So, but it is a really interesting question, and I think that we need to find out, as these disparities happen, to notice, to find a way to do it without making things pigeonholing any one cultural risk factor to determine who should get tested. And I don't really have the answer to that, but so I don't know if any thoughts about, in terms of, should we test everybody, and then should we really look in communities at access issues and what are some of those things, Dr. Kennard, that might be persistent barriers that affect some communities more than others?
Two thoughts based on that, Sean. One is that's the question I have for future translational research. What is it about having a race or ethnicity on a form of Hispanic or Latinx that makes you more likely to have a severe outcome from COVID? Is it simply confounding by your socioeconomic status or getting care late, or is it something else that needs to be built into therapeutic trials and making sure that we're bringing the highest risk, most equitable population into those trials? In terms of being able to test everyone and allocate testing to different communities, it goes beyond NorthShore, but even in NorthShore, thinking about where our immediate care testing sites are, that's where we're going to pull patients in. So having testing at Old Orchard, for example, instead of maybe Winnetka or Lake Forest, it might bring more equity to that population and community to have testing locations there. The fact that we have a drive-through test access point at Old Orchard brings a lot of equity to drive-through testing there. And again, we're not the only healthcare system. Someone needs to be making sure that our testing sites are allocated properly.
I think NorthShore's done a really nice job with that, with the immediate care sites. I know at some points people felt there were too many of them, but when COVID hit, all of a sudden having this huge access points across all different areas of the North Shore has been wonderful for allowing people to get in. So the super sites specifically have a lot to do just with size and space, but they are well distributed across the sites. But we are now doing COVID testing at any particular site. So all the way from Des Plaines down to Skokie Commons down into the city, we have that capability. So as far as distribution of those resources seems to be pretty well put for patients who are willing to come in.
And I think that will be ever more important as we enter the flu season as well, and having those more access points for our population, and hopefully the ability by then to be able to more quickly turn over our rooms so that we can see more patients in all of those sites.
Very good. So my AirPod battery died, so I'm using my speakerphone. If you all can't hear me, please let me know. Oh, I have, yeah. And just before I move on to the next question, Dr. White Van Gompel responded, I think there are many different ways that have been validated as measures of structural racism experienced by a patient. STH screening, index of concentration at the extremes, using census tract data. So, yeah, so it's a very good point. I think our experts in the psychometrics of measuring structural racism that ought to inform how we approach this going forward. And that segues into the future translational research directions of this work. So there are several things that stood out from this study. The observation of anosmia being highly predictive, lower systolic blood pressure, and other subtle things that were more predictive of case positivity. So it seems to me that there are a number of different streams of translational work that need to happen, and there are investigators across multiple institutions developing predictive models using all the data available from electronic health records. There's research into new surveillance approaches that take into account the spread of virus through digital contact tracing and more refined testing of the viruses. There's a whole range of areas that one can go next to, but we really need better data at a population level on how to manage an epidemic. And I think that that's where we need transdisciplinary experts at the table to guide health policy decisions, because as it is, it seems like there's quite a bit of fragmentation in our public health response. And yet, health systems have stood up programs very quickly using the best evidence. So I think there's a whole range of science that's needed, as well as health equity work to make sure that all groups have equal access to testing and services. So I'd welcome any other comments about future translational research directions from the speakers and members of the panel, and also from participants.
So I think just looking back at the concrete results from this particular study and knowing that there is not at this point a data set, a risk factor set that can accurately determine who is going to be positive or negative, that absolutely is an area for future translational research. Every few days, as Dr. Kaplan is, either getting an email from me saying, hey, you should add this to the algorithm, or looking at the primary literature herself, we are iterating our processes internally, but that requires not just templates for immediate care, but for Tyler and all of our colleagues in HIT to change all of the systems for all of the team working our Health 9 line and the e-visit protocol. And it's difficult to stay nimble on a system level when things are changing. And so if you imagine NorthShore is just one organization across the country, this idea of translating new research, we found that XYZ symptoms might be associated, well, in a national sample or your sample perhaps, but then when applied to NorthShore, is that true? And then iterating them into our system, that takes a lot of time. So I do think at some point we need to give ourselves a pat on the back, we're doing a good job, and then continually consider how to bring this new data into our protocols.
Absolutely. And we have a question from the chat. Is NorthShore considering doing pool testing of asymptomatic or low-risk samples? It would be interesting to try to predict negative samples and pool them to conserve resources. Great question. Tyler, Dr. Kaplan,
We'll have to ask Dr. Call to chat in again.
Okay.
I
know that.
While maybe Dr. Call is chatting in, we've had some discussions about asymptomatic, not necessarily pooled, but right now, not going in that direction other than what we're doing currently for pre-surgical, pre-procedural. One of the reasons for that is this continued pressure on the availability of testing supplies. While we're in a good place, I think that is still a concern as we look at additional testing ramping up right now in kind of this second wave of the first wave, and then what wave 2 looks like as well. I think if we had certainty with that, that may add to the discussion, of which I'm sure there are other factors, but that's one of the things that sticks in my mind.
Thank you. And I think that this is still something under consideration nationally, and it's at the state level. So it's a really interesting question. Very good. The other comment I had was the potential of using information learning from studies like this, but also from the electronic medical record using artificial intelligence, whether algorithms just like Dr. Kaplan is updating the algorithm every couple of days for this, can a computer do that and make it much more and more sensitive in terms of things about the patient's medical history, their zip code, the clustering of cases, and so forth? Can electronic health records using AI get to a point where we can be proactive about testing and not waiting for patients to show up? Would be a question I would have. And I don't know the answer to it. That's why I'm asking if there are any AI gurus on the call.
I'm going to defer to Tony Solomonides and Nirav Shah.
Good idea.
The interesting thing about artificial intelligence is that you're teaching the intelligence to recognize a pattern. So if the person who builds the intelligence builds in biases to the training program, those biases will be amplified by the AI. And so it's just very interesting to me seeing all of the young people who are being exposed and being our primary cohort for COVID now, whether AI would be lagging in identifying that shift or not. I think looking at the news and what people are capturing with their iPhones, seeing people doing risky behaviors might be just as good or the best AI we have.
Yeah. Well, maybe that's where things are going to go. There'll be mobile health and tracking patients, and that it's frightening but exciting at the same time that we could trace based on some testing algorithm that would involve people consenting to be tracked, as well as with the test results and using some kind of feedback loop to hone in on minor outbreaks and contain them. I think at this point we're coming up towards the end of the seminar. I want to make sure that I just thank our really outstanding speaker and panel. And if you have any additional comments or questions now, there might be time for one more before we move on to just the process of following up with evaluations of the seminar today. So speak now or forever hold your peace. And then Rachel, if we can go to the last slide. So
as you wait for any other final comments, I would just say that listening to the end of our conversation, what I feel proud and happy of is that patients consider NorthShore a trusted partner for their healthcare, and that with Dr. Cunard's perspective from the community, that we were able to bridge that. You can have the most successful screening system, but if patients are afraid or unwilling to get care, that is a barrier to its success. And what I've heard today about NorthShore's responsiveness and ability to put this system together, just from the folks on the call, but the folks in the lab and everyone who participated, I think we should be applauded for meeting our patients' needs.
You're here. Yeah, I agree. And thank you all for taking the time to participate in our first outcomes research seminar. So if you have any questions, Dr. Oshman had provided her email regarding the talk, but the contact information is on this slide for Rabia Ali. And stay tuned for our next seminar, which is going to be Tuesday, August 18th, when Dr. Tom Ganadik is going to present on the NorthShore Convalescent Plasma Collection Program. And future seminars will also focus on the therapeutic clinical trial response at NorthShore, and we'll be inviting outside presenters as well to bring people into some mutual awareness and collaborative opportunities across Chicagoland. There's also an evaluation. Please complete a brief survey that you'll be directed to after the webinar. And the link to the survey is also in the chat box, I believe. And then finally, a recording of the seminar will be distributed to all attendees. So we will send that out in due time with a link to this video, and that will be the case for future seminars as well. So on that note, I wanted to take one final opportunity to thank everybody. That was a really wonderful, impressive body of work that was presented, and the conclusions have a lot of implications for policy practice and the future of how we go about trying to figure out whom to test and really how to apply this in our practices and our communities. So thank you all very much.